Okay. Good morning, everybody. Today we're going to talk about antifungals. And first, let me introduce myself. My name is Dr. Ana Paula Velez, and I am one of the infectious disease attending. And today we'll be talking about antifungals. So basically, we're going to be talking about each individual class. And then at the end, close to the end, I'll be talking about some microbiologic considerations of candida infections, particularly some species and the treatment that we should be using for them. Feel free to stop me if you have any questions. Okay. Let's start with a case. A 40-year-old female with history of AML. Neutropenia for 20 days. Sounds like all of our patients in the fourth floor. She complains of shortness of breath, cough, and fever up to 102. She's currently on vancomycin, levaquin, cefepime, and acyclovir. You order blood cultures and they are negative. Then you order a CT of the chest. This is what you see. Can anybody volunteer to see what you guys see here? Can anybody describe what this is? Nodular lesion. What else? Halo sign. And what about this air here? Is that the halo sign or the air crescent sign? Air crescent sign, because this is hair here. If we saw a halo sign, will be a nodule surrounded by ground glass. Okay. Then you call the pulmonary fellow on call ASAP to perform a bronchoscopy with bronchoalveolar lavage. And because we are in a very prestigious cancer center and everything gets done as soon as possible, 5 minutes later, Dr. Sandin calls you to chop the smear and wants to give you some teaching. Okay? And this is what we see in the smear. Any volunteers to describe what this is, or just the description first? And then, first of all, what is this? Hyphae. Okay, hyphae with septations. And then the angle is 45 degrees. So that's consistent with what? Aspergillus. And let me go back to this lesion here. So basically there are two classical signs that you can see on CT on Aspergillus, and one is the halo sign and the other one is the air crescent sign. The air crescent sign is a nodule surrounded by air and is more consistent with aspergilloma. Here in this one we see a little bit of ground glass, perhaps consistent with some alveolar hemorrhage. And if we had the halo sign, we will have a nodule consistent with necrosis surrounded by ground glass consistent with alveolar hemorrhage. These signs are typical of Aspergillus, but we don't always see them. The problem with fungal infections in immunocompromised patients is that the bronchoscopy is not always positive for cultures. Therefore, we have the clear diagnosis when we have the CT findings and the microbiological cultures consistent with that, or possible diagnosis, and that's when we have the immunocompromised patient and the CT findings consistent with nodules or like I just described. Okay. You decide to start the patient on treatment, and what will you do? You start caspofungin, fluconazole, 5-FLUCYTOSINE, micafungin, caspofungin and voriconazole, or amphotericin B. Nobody knows all of the above. E or A? Okay. Any other volunteer? E. Any other volunteer? More votes? Jose. What about you? Oh, you say already. What about you? Not sure. What about you? Go for E, Aliyah. There's a good option too, but will clarify more these points. What about you? E. What about you? E. So I don't know if the rest of the group say E because 2 or 3 say E or what. But anyway, caspofungin is a static for the treatment of Aspergillus, and amphotericin it could be indicated. However, a recent paper that I'm going to show you later discuss the two options, amphotericin B versus voriconazole, and voriconazole had better outcomes and less side effects. Why caspofungin and voriconazole? There is another paper with the reference that is going to be in one of the slides that discuss that caspofungin and voriconazole had better survival rate 3 months after treatment compared to voriconazole alone. So this is the one that I was telling you. The right answer is E. So amphotericin is not wrong, and you can use it if you cannot use the combination of pifen or micafungin, and but the combination is better. And caspofungin or any other echinocandin alone will need something cidal. So this is the paper that I was telling you. The combination of pifen and caspofungin is associated with better outcome compared with voriconazole alone for patients receiving salvage therapy to treat Aspergillus. And that was discussed on this reference here by Dr. Marr, well-known doctor in the infectious disease field, particularly in the bone marrow transplant patients. And Dr. Bennett did a review discussing what is salvage therapy for Aspergillus and discussing why or when you will add micafungin to bifen. And basically, if the patient doesn't improve with just bifen alone, or the patient is too sick to wait, the combination will be better. So, and going to the answer of the other option, amphotericin B, this paper published on 2002 discussed voriconazole versus amphotericin B for primary treatment of Aspergillus, and it basically says that voriconazole has better outcome than amphotericin B with less side effects. Okay, so this is the introduction to the different classes of antifungals. We have the polyenes, we have FLUCYTOSINE, we have ECHINOCANDIN, and Azoles. We'll start with the echinocandins. They act by inhibition of the synthesis of 1,3-glucan, which is a polysaccharide that is important in the cell wall of many pathogenic fungi. So far, these are the three echinocandins that are FDA approved: caspofungin, micafungin, and andilafungin. The indications are esophageal candidiasis, invasive candidiasis, particularly candidemia, and invasive aspergillosis. For these indications, remember to use it along with an azole type of antifungal, particularly voriconazole. Esophageal candidiasis, particularly in patients who have HIV who have been heavily treated with fluconazole, in which some types of candida resistant to fluconazole can be seen, or in patients who are neutropenics or stem cell transplant patients with candida esophagitis. The main side effects are liver LFTs abnormalities, histamine release, and remember caspofungin can reduce the levels of tacrolimus by 20%, but it has no effect on cyclosporin levels. So Daniela is gone now. So this, let's look any volunteer. How many azoles do you guys know? How many? 5, 3, 4. Ketoconazole, miconazole. Yes. Actually, this is from the Amazonas, and here in the back is the Amazonas River, by the way. So the main two classes are imidazoles, including clotrimazole, ketoconazole, and miconazole, and the triazoles, fluconazole, intraconazole, voriconazole, and posaconazole. Which of the following represent the mechanism of action of the azoles? Sorry, there's a word missing here. A. Inhibits the synthesis of the membrane steroids. B. Damages the cell wall. C. Interferes with the glucan synthesis. And this should be D. Creates pores in the cell membrane. Which one? A. Very good. It targets the ergosterol synthesis by inhibiting the fungal cytochrome P450, preventing the conversion of lanosterol to ergosterol. Okay, so the indications for the imidazoles include superficial mycosis, cutaneous and vulvovaginal infections caused by Candida albicans, Tinea corporis, pedis, and cruris. Triazoles that we discussed, we say that was fluconazole, voriconazole, posaconazole, and so on. This is the newest one coming, rabuconazole, which is in phase 2. And just for your information, voriconazole is structurally related to fluconazole, of course with some modifications, because fluconazole doesn't cover molds, whereas voriconazole does. And the structure of posaconazole is similar to that of intraconazole. The triazoles are active against Candida species, Cryptococcus neoformans, Aspergillus, but again, fluconazole doesn't cover molds, so that will be an exception. Fusarium species and other molds. Among the triazoles, posaconazole appears to be the best to treat zygomyces. Voriconazole has no activity. The main side effects include GI side effects, skin rashes, LFTs elevations, liver failure, alopecia, and aldosterone-like symptoms. The mechanisms of resistance: alteration at the target binding site, increased target expression, or cellular efflux pumps. Now we're going to move to some of the microbiologic considerations for Candida species. Remember that Candida or Candidemia has become the third leading cause of bloodstream infections in patients, particularly ICU patients, preceded only by coag-negative staph and staph aureus. So it's more important than we think. And the cultures are not always sensitive. The Candida organisms are very big, so in order to see it in the cultures, A, or the patient has to have a lot of organisms, or B, we have to take a lot of cultures to see it. So it's based on your clinical suspicions. There are some risk factors that you have to think of in somebody who's presented with fever and the blood cultures are negative and has leukocytosis. And these risk factors include prolonged hospital stay, prolonged use of antibiotics, use of steroids, chronic indwelling catheters, GI or cardiovascular surgeries, and obesity. And remember that Candida albicans, tropicalis, and parapsilosis are still highly susceptible to fluconazole. The susceptibilities range from 21 to 28%. The resistance is only less than 3%. Remember that the infection due to Candida glabrata is increasing because we are using more fluconazole. Remember that Candida glabrata is less sensitive to fluconazole and ampho-B than other Candida species. So the ideal drug will be a echinocandin type of drug, such as caspofungin or micafungin. The Candida glabrata has the ability to develop high levels of resistance due to efflux pump inductions. These efflux pumps can be overcome by very high doses of fluconazole if it's present. Breakthrough infections have been seen in patients with stem cell transplant receiving voriconazole prophylaxis. So the teaching point is, if you see a Candida glabrata with an MIC equal or greater than 64 to fluconazole, it's better to avoid voriconazole because of the concern of cross resistance. Remember that Candida lusitania is resistant to ampho-B, and azoles are still, you can still use azoles. Candida lusitania can be susceptible in 96 to 100% of the cases, and echinocandins are good too. Remember that Candida parapsilosis has a higher MICs to echinocandins, so you want to use azole type if you can. And the incidence of Candida albicans is still pretty sensitive to fluconazole, with few exceptions, and I mentioned them earlier. Candidiasis in HIV patients who have been previously treated with fluconazole, or some of the patients who have a history of stem cell transplant. What about Candida krusei? Candida krusei is intrinsically resistant to fluconazole. And why is that? It has a different cytochrome P450. And Candida krusei can be seen where fluconazole has been used before prophylaxis. Bless you. And Candida krusei is the second leading cause of candidemia in Spain and other Latin countries. For us, it's Candida glabrata, is the second after Candida albicans. And however, for Candida krusei, as opposed to Candida glabrata, in Candida krusei you could use voriconazole because voriconazole binds more efficiently to the cytochrome P450 of the Candida krusei versus fluconazole. But again, it's best to be avoiding Candida glabrata when the MICs to fluconazole are greater or equal to 64. Okay, so let's say that you get a call from one of the nurses and say, "Oh, doctor, this patient, the blood cultures are growing Candida. The species are not yet identified." What some of the questions that you had to ask yourself in order to pick up the right antifungal is: A, is the patient stable or unstable? B, is the patient neutropenic or not? C, look at the cultures and see if the patient has been colonized with krusei or glabrata, or if the patient is being treated before with fluconazole. If any of these questions you answer yes, then you shouldn't use fluconazole. You should use ideally an echinocandin. And if you answer no to all of the questions, then fluconazole could be a good option. Going back to your patient at Moffitt. The patient mentioned previously improved for a week, but it's Friday 6 p.m. and the patient develops shortness of breath again. She undergoes a bronchoscopy and Dr. Sandin calls her again to look at the smear. And this is what you see. So Any volunteers to describe what we see here? It's a hyphae, right? And is there any septations here or not? No. What's the angle here? Yeah, almost 90 degrees. So what is this consistent with? Zygomycosis, yes. What's the antifungal of choice? This is also a picture in the Amazon, and you see the Victoria Regio, I believe is the name of this plant. It's beautiful. But anyway, what's the antifungal of choice for zygomyces? Is it fluconazole, andilafungin, nystatin IV, amphotericin B, voriconazole, or only Dr. Eller knows the answer? What is it? It's okay. Guess our. Sorry? Amphotericin B. Yes, that's correct. That's the drug of choice. Amphotericin B. I did not list here posaconazole, which has activity against zygomyces as well, and it's approved for salvage therapy. But if you can use amphotericin B, you may want to pick up amphotericin B. And also, the problem is that when these patients have zygomyces, they're so sick that they cannot tolerate raw. And remember, for posaconazole, you have to be able to eat a good fatty meal in order for it to be absorbed. So if they have zygomyces, sinusitis, and the face is completely disfigured, they won't be able to swallow or to eat. So okay, so once again, this is in the Amazonas. What's the mechanism of action of amphotericin B? Mitochondrial toxicity of the fungi, disruption of the cell membrane, disruption of the cell wall, inhibites the fungal DNA synthesis. Which one is it? B. Okay, what else? Any other volunteers? Which one? A. What else? So we have. So is it the wall or the membrane? And remember that the wall is composed by polysaccharides, and the membrane by and the echinocandins act at the cell wall, and the azoles at the level of the cell membrane. And that's probably why the rationality behind of using caspofungin and voriconazole together for the treatment of aspergillus, because each agent acts at the different level of the fungi. One acts in the level of the cell wall and the other one in the cell membrane. So actually it's B. You were correct. It acts by binding the ergosterol and it formates ion channels, leading to the destruction of the cell membrane. And basically we have three types of amphotericin available. We have the colloidal presentation, the lipid complex or able set, the liposomal amphotericin B or ambisome, and basically the main resistance has been associated with variations in the membrane sterols. The activity is against most Candida species with few exceptions, and I'm going to be talking about that shortly. Coccidioides, Aspergillus, Blastomyces, Cryptococcus, and Sporothrix. There are some uses of amphotericin as far as local infusions that include blood infusions for candiduria, peritoneal infusions, intraventricular administration for CNS, some of the CNS infections, and intravitreal and subconjunctival injection. I personally I don't have experience with that. I know some of the other attendees have used it for intrabladder infusions. Which of the following Candida species is resistant to amphotericin B? Albicans, tropicalis, or Lusitania? Yeah, and this is one of the corrections what I wanted to do. Of course, it's highlighted. It's like so obvious. So Lusitania is resistant to amphotericin. However, you could still use echinocandin or fluconazole for that. And also remember that amphotericin is less active against Guillermondi, and the MICs from Candida galbrata and Cruciae are also increasing to amphotericin. So again, the best drug to treat Cruciae and galbrata is an echinocandin type of antifungal. There are some side effects including nephrotoxicity, hypotension, hypertension. This nephrotoxicity is less commonly seen with the lipid formulations. And hypotension, hypertension, vestibular disturbance, and anemia, also chest pain, are some of the side effects that can be seen with amphotericin infusion. Now, what about liposomal nystatin? Was the first antifungal POLYENE created. It binds also the ergosterol in the cell membrane of the fungi, just like amphotericin, but is highly toxic when it's given orally and parenterally. So that's why we don't have it at this point. I mean, no oral. I'm sorry, IV. We can use this locally for oral thrush. Which of the following is the mechanism of action of the I'm sorry, it's missing a word. 5-FLUCYTOSINE. Damage the cytoplasmic membrane, inhibits the DNA synthesis, interfere with the synthesis of the cell wall. It's unclear at this time. Only Alia knows the answer. The mechanism of action of 5-FLUCYTOSINE. Which one? B. You say B. Any other guess? And actually it's B. You're correct. Just remember the name. You know, like to formate the DNA, you need some of these components. So it's taken up and converted by the cytoplasm to 5-fluorouracil, I cannot even pronounce it, which inhibits the DNA synthesis. And it was originally created to treat leukemia. The main activity is for Candida species, Cryptococcus neoformans, particularly when you're going to do induction treatment for Cryptococcus meningitis. It is used along with amphotericin to reduce the chances of relapse. And has no activity against other molds, pretty much. Side effects include GI intolerance, neutropenia is a big one. Another indication for 5-FLUCYTOSINE is when you have a pretty bad deep infection like an abscess, that you want to use it along with amphotericin or endocarditis. However, neutropenia is a big side effect. Another side effect is bowel perforation. So keep an eye on that. Again, it's generally not given as a single agent. Cryptococcus meningitis, Candida infections involving deep tissues such as meningitis, endophthalmitis, endocarditis, and peritonitis. Other antifungals that I'm not going to be talking about today include terbinafine, griseofulvin, amorolfine, cyclopirox, and their use only Dr. Green knows it, since he's been at Moffitt long enough to tell. Okay, and this is just to tell you a little bit. This slide illustrates the different parts of the fungi that we were talking about. The cell wall, here it is, and the cell membrane, which the key component of the cell membrane is the sterols, and cell wall, the glucan. That's why I wanted to put this slide here. And that's the end. This slide, when I went to Rome, I saw a guy walking with this shirt, and I'm from Colombia, so when I saw that I was like, what? So I couldn't believe it. But anyway, it says, are you protected against aspergillus? You know, smoking marijuana is a risk factor for aspergillus. So, and that's it. Any questions? Okay, thank you very much.